Hello, everybody. Welcome to the webinar, How to Improve Women's Heart Health, Lessons from the US and China. Thank you so much for spending some time with us today. I'm Helena Shao, Associate Director at Columbia Global Centers Beijing, which is the regional hub in China of Columbia University to facilitate and promote academic exchange and research collaboration between our students, scholars with counterparts in the region. Today, we're very glad to invite doctors and research scholars from China and the US to talk about the challenges to equitable cardiovascular care that women face in two countries, and provide suggestions in reducing heart health risk in different health systems. So here, special thanks to our great partners, Beijing Medical Valley of Capital Medical University, the Women Creating Change Initiative of Columbia Center for the Study of Social Difference, Columbia Medical Center, SubChina, and others to support and feature this event. A healthy heart is something most people take for granted, especially for women. When we hear the words heart attack, more often than not, we worry about our aging parents or our overweighted spouses instead of ourselves. However, the cardiovascular disease, as all of us know, is among the leading causes of death in both US and China. Luckily, there is a time when all people can, should get serious about the cardiovascular health and commit to take practical steps to improve it. It is February, just this month, American Heart Month. So hopefully this discussion tonight or this morning we're about to learn will plant correct mindset and good practice suggestions in our mind, which will help us to prevent unnecessary risks. So before we get started, just please be reminded that if you have any questions or comments during the discussion, please type them into the question box at the bottom of your Zoom screen. Our moderator will try to bring them up during the discussion or after it. So now let me give the stage to Dr. Sonia Talani, the co-director of the Women Heart Health Center at Columbia University, to start the discussion. So Dr. Talani.
Thank you so much, and thank you to the Global Center Beijing and also to the Columbia Center for the Study of Social Difference for collaborating for this great program. So I'd like to begin by introducing our panelists. I'll begin with a close friend and colleague of mine, Dr. Elaine Wong. She's an electrophysiologist and associate professor of medicine and the director of the EP Research and Electrophysiology consultant for the Mother Center. The Mother Center is a unique program at Columbia that is involved in taking care of both the high-risk mothers who have cardiovascular or other medical issues. Next, we have from our colleagues in China, Dr. Rong, who is the Associate Professor and Chief Physician of the Department of Cardiology of Beijing Tsinghua Changgung Hospital. She specializes in dealing with common cardiovascular disease and complex and critical diseases with a focus on arrhythmia, cardiac pacemaker implantation, and programmed follow-up. She also specializes in diagnosing and treating heart failure, cardiomyopathy, hypertension, and hyperlipidemia. Next, we have Dr. Ying, attending physician in the Department of Cardiology of Beijing. She is a member of the National Clinical Research Center for Geriatric Disease and the Chinese Alliance for the Prevention and Treatment of Geriatric Cardiovascular Disease Committee and the Royal College of Physicians in the UK. And finally, we have Dr. Si Xu, the Chief Physician and Master Supervisor and Director of Health Management Center of Changgung Hospital, Capital Medical University. She is also a standing member of the Health Management Branch of the Chinese Medical Association. So thank you all, distinguished colleagues, for joining us. I want to start with just a question that I'd like each of you to address, and that is, as Helena mentioned, we are very well aware that women aren't treated in the same way that men are. Often women's heart disease goes unrecognized, often it goes undertreated, and for these reasons, often the outcomes aren't as good for women with cardiovascular disease than men, even though in many communities, heart disease is the #1 killer of women and kills more women than men annually. So I'm wondering if you could tell me, what are the gender disparities you've observed in your own practice and community around these ideas of access, diagnosis, and treatment of cardiovascular disease? And I will start with whoever would like to start.
So maybe I can share some of my thoughts. So basically, I totally agree that women are, most of them probably are thinking cardiovascular disease as a man's disease. So some of the time they may feel that they won't get a cardiovascular disease. However, actually the data from previous studies already show that from the epidemiology point of view, actually cardiovascular diseases are the leading cause of death for women in China already. And it is also in an increasing trend. Despite globally, we see there is a decreasing trend, but not optimistically, that in China, actually for now, we are still seeing this trend is getting higher prevalence of cardiovascular diseases, as well as mortality and morbidity. So there are many reasons for that as well. Actually, not only for women, for men and women, we should say that the total prevalence is increasing. However, if we look down the reasons for that, we can attribute to an aging society and probably a changing in the diet and the anxiety in the society, as well as daily life changes as well. So all of this adding to the increased trend. But at the same time, it also highlights that this is very important for us to do more work for the primary prevention of cardiovascular diseases as well. I think, yeah, that's all from me.
Thank you.
And I just want to talk about smoking. The smoking rate maybe is popular in men, but I think in women the smoking rate is low in China. But there is another fact: the second-hand smoke are important in the CVD risk factor in the woman in China. Second-hand smoke rate is about 45.7%. I think maybe it is a very important risk factor for the CVD. And another thing is the increasing rate of the smoking rate among female teenagers. So it is another factor we need to focus on, I think.
I just agree with what the Professor He and the Professor Xie said. I think the difference between the women's cardiovascular disease is true because for Chinese women, we do have some different characters. So just we know that many Chinese women are professional women, so they need to do their work well, or do also based on the traditional ideas, they need to take their much time to take care of families, about children's education, to deal with some relationship like mother-in-law relationship, daughter-in-law relationship. So this make them have great pressure. So I think maybe the pressure in China for Chinese women maybe is more than the women in other countries. So just we know that pressure is also a risk factor side for the cardiovascular disease. So I think maybe this is one of the very important reason. The other reason for the women's heart disease, I think, is that maybe they don't pay more attention to their own health. So they think that maybe they have the relatively healthy lifestyle. They don't have the very high risk, like some risk factors of heart disease, like hypertension, diabetes, like that. Maybe they think men have more risk of that factors risk. So risk factors. So they just think I'm healthy. I don't need to pay attention to my health. So they don't take some time to do some screening, to health examination, to find some risk factors of heart diseases. So I think they need to pay more attention for the prevention of for the diseases, and also take some actions to do that.
I love what you said there, because I think you touched on a lot of issues that I think, and I think Dr. Wong will speak on this, but there was just a couple of questions I had about for our American participants is, we've had a major issue with heart disease awareness in women. So we have the American Heart Association has a campaign called, Wear Red, or the Red Dress campaign, to try to work on this. So, but what we found in the US is that, there really hasn't been an improvement. So only about, maybe 60% of women realize that heart disease is the #1 killer. And in certain communities, in our minority communities, only 1/3 of women realize that heart disease is the #1 killer of women. There's just this, a lot of women still think breast cancer is the only thing that they have to worry about. And just like the points that you brought up about the woman putting herself behind everybody else and playing the role of the caretaker and worrying about the family members and the children and the running of the household, these are some of the things that we certainly see here. In China, are there, and then and Dr. Wong, then I'll have you jump in. Are there any sort of public health campaigns that are directed specifically to women, that have gained more success than what we've seen in the US? If I'll call on any of the panelists to comment on this.
Actually, I don't have a data for the awareness of the total cardiovascular diseases, but to me, there is a data suggesting that for hypercholesterolemia, so the diagnosed rate and the awareness rate was less than 10%, which is somehow very limited to me.
Yeah, that's remarkable. So you're saying that, only 10% of women realized that they had high cholesterol.
Yeah.
Wow.
Yeah, I mean that most of the women here I see, they some women with good education background, those well educated, they will seek for more medical advice, and those who are undereducated. So some of them are just, they don't know how to prevent cardiovascular diseases. They are just worried about their families more, as Dr. Chu has mentioned just now.
Yeah, and I'll let Dr. Wong hop in here, because I think these are some of the similar, issues at play that we see in the US as well.
Well, thank you so much for my colleagues in China sharing that. Really, women all across the world, we have very similar perspectives, putting our family, our children and our partners before us. And that's something really the COVID pandemic, I think, has made it more stressful for all of us, especially with young children. We are trying to balance our jobs, and in this new generation, or younger women are more higher up, like executives, and better educated and have more jobs which are needing of their. One thing that we brought up here a lot in the
我们美国经常谈到的呢，就是数字健康。现在大家每个人都有，比如说电子手表可以监测自己的心率，我们可以 通过这些体表的可穿戴的设备监测自己的心脏状况，通过这些数字健康设备，我们可以监测自己。那我想知道，在中国是不是也有类似的设备，比如说小米2等等？那中国在这方面是不是比较相似，还是有一些差别呢？
I think maybe there are some monitoring
中国
just like Huawei has
有一些
Huawei watch can monitor
监测的设备，比如说华为手表等等，可以监测心跳频率和血压。
I think just like many universities
比如说很多大学，他们设计
EKG patch
一些
I think maybe it is
监测身体指标的设备，在中国也越来越流行了。正如刚才图拉尼博士提到的，如果说教育水平比较高，也有更多的钱，那就买得起这些设备，能够监测自己的状况。但是如果说没有足够的知识和资金的话，那就很难使用这些设备。那您是不是也这样认为？比如说年轻的女性呢，更加愿意去多锻炼，关注自己，但是年长的人士可能不太熟悉这些设备。您是不是认为也存在这种差异呢？比如说，有的人太过于关注自己的心率，但有些人却非常忽视呢？
I would say, to my opinion, if we want
我觉得，
to talk about the high technology,
如果大家关注高科技的话，比如说手表，
the iWatch thing, those things are probably thinking about
这些设备可能更
so most of them
倾向于关注男性的喜好。
my friends, among them the male friends, mostly they
我的男性朋友们
devices, but female
非常喜欢去追新的设备，但是可能有一些女性不太愿意尝试很新的设备，
the high technology ones.
尤其是那些高科技的。这是我的一点观察。另外呢，就是万博士和中国同事都提到的，就是获取医疗保健的能力，包括防治的能力。在美国呢，很多年轻女性在更年期前，主要是通过自己的妇科医生等等得到这些护理的。他们
觉得这些
可能在生孩子的时候就认识了这个医生，然后一直跟这个医生一起。
患其他病的时候，他们就不去看这些医生。此外呢，美国心脏协会还表示，如果是要将特定的一些医生加入到这样的一个心脏病治疗的讨论当中来，表明他们去看医生的时候，不仅仅是去进行一个某一项项目的检查，而也应该检测自己的胆固醇，检测自己的血压，检测自己的血糖，检测他们是否有良好的一些健康习惯。那么在中国有没有一些相应的一些倡议和策略，让他们进行一些预防性的一些保护？那么你们能不能或者讲一下，在农村和城市之间有什么样的区别？不同的举动如何影响女性对疾病的预防呢？
Dr. Shi?
Yeah, I mean, for most cities, if we want to talk about
我觉得呢，在大多数城市当中，如果要是我们想讲一下一些主要城市，包括北京啊、上海啊，大多数人呢，他们经常会去做体检，就大多数1年或者是2年都会做一次体检。那么在体检之后呢，他们会去见主治医生，然后去测血压之类的。他们一般会测一下自己的血液。
Of course, including to check for the other bloods as well, and ECG.
检测一些血液的其他的一些指标，比如说 ECG 等等，这些都是比较普通的一些体检。但是对于农村地区或者是比较偏远地区来说呢，
probably are not getting enough
大多数的女性都没有办法做足够多的体检，也没有很好的机会去看一些医生。
China is the country with
像大家也知道，中国幅员辽阔。
So if we are talking about
地区呢差异非常明显，所以如果是我们要想说不同区域之间的一些差异的话，那么有一些人呢可能由于经济上或者其他的一些问题，就没有办法去看医生。
Dr. True?
Yeah.
楚教授这边有什么要说的呢？
Just as Professor Xie said, we do
我认为就像刚刚谢教授说的一样，我们在城市里的人呢会经常去做一些体检。
So, our government have some, just as I know.
我们的政府呢，就我本身而知道的一些知识来说呢，我们政府现在呢也会举办一些免费的体检，对一些老人举办这种免费的体检。
So it's free, but it's
此外，对女性方面也有一些体检项目，全部都是免费的。
We do some many works for the health management based on the data. So we can give some advice to them how to improve nutrition, just improve the exercise. So we can get the basic data like blood pressure, like your body mass index, like that. So we can did some work for the prevention. So I did some clinic work for 16 years, and in recent 10 years, I just focus on the health management. So it's just the prevention for before the disease happens. So I think it's a hard work to like people to love to do to change their lifestyle, but it's need to have they deserve to do that.
I mean, I think you bring up some excellent points, and I think it kind of ties to something I know Dr. Wan and I see in our practice is that not only are a lot of women not aware that heart disease it should be something that they're worrying about, but they don't understand what their risk factors are, so, for example, like a family history or smoking or cholesterol or pregnancy disorders like preeclampsia, and gestational diabetes, I think these things are not as well, understood by the general public, particularly in areas in sort of women who are maybe not as highly educated. Dr. Wan, do you want to talk a little bit about, this idea of understanding risk factors and how we, kind of what you see in your practice about people's understanding of what puts them at risk and what they need to do lifestyle-wise?
Yeah, I think all of us agree that a lot of the women compared to men have very different presentation symptoms of cardiovascular disease. For example, most commonly, what we're taught is for myocardial ischemia or myocardial infarction, their symptoms are very typical. So I think one, modifying risk factors is important, and then education for them to understand, what are the presentation of their symptom. Something that Sonia, you and I have talked about is also, as electrophysiologist myself, heart rhythm disorders are sort of very different in women compared to men too. Women seem to feel their heart, more sensitive when they feel palpitations, and their heart rate can go much faster and have more symptoms than that. So also that is a little bit different. And sometimes it could be a normal rhythm, or it could be an irregular rhythm. And something we talked about, the commonalities, of our two different worlds, in East and West, about the stresses that women face. But some things that are a little bit different are anticoagulation strategies, because Asians have different levels of anticoagulation, would put them at risk for hemorrhagic stroke compared to in the US, which is a more, you want to talk about heterogeneous, the United States is definitely much more heterogeneous in the different ethnicities and patient populations. So yes, definitely agree that there are atypical presentations and not enough screening and understanding for women. I just wanted to take just a few minutes, if you can comment, Dr. Shi and Dr. Chu and Dr. He, about anticoagulation strategies for atrial fibrillation in China, and what are, for women specifically, how that's different between women and men. Because, for example, here we use a lot of the novel oral anticoagulants like Eliquis, but for Coumadin, for example, I don't know if most people know, for atrial fibrillation, your INR levels are different from ours. For ours, we use INR 2 to 3. Can you talk about your experiences and your treatment guidelines?
It's a good question. I just want to talk about some AFib in China. I think in the anticoagulation rate in China, I think despite the increasing rate, it is still low in China. In the Garfield AF study, the anticoagulation rate in China is only about 31%. But from the data in the Chinese AFib registry study, Garfield, the anticoagulation rate was about 36%. But there is many differences between women and men. In our center, Beijing Tsinghua Changgung Hospital is just opened in 2014. So in 2017, the anticoagulation rate in our center is about 50%. But we have many measures to improve the anticoagulation rate. One of them, we just built a special clinic for the AFib patient. And we have the MDT team to treat the AFib, just like the MDT, including the cardiologist, the emergency physician, and some neurologists, and the other just like nurse and the case manager. So we have built a system for the follow-up. So in the other hand, we just design apps to give the attending doctor the patient's Charles score, so to give some advice. So from this registry, the anticoagulation rate is increasing, and I think there is another other hand factors, just like no-arc, because in the Alpha era, it is very difficult to monitor the INR. Maybe for some patients, especially in the rural area, it is difficult to monitor the INR. So when the no-arc coming, the anticoagulation rate is maybe increasing now. I think this is my opinion. Okay.
Another thing that has come up a little bit, and we kind of touched on this a little bit, is the disparities between different groups of women, and the levels of which they have access to care. a lot of times we've also found disparities in women being studied in clinical trials. So for example, in the United States, our guidelines for how to treat, our common cardiovascular diseases, heart failure, high blood pressure, hyperlipidemia, atrial fibrillation, a lot of them are based on studies that have, only about 1/3 of women involved in the clinical trials as participants. And a lot of that is thought to be because there aren't actually a lot of women doing cardiovascular research. And until recently, I think there haven't been as many women in cardiovascular disease as researchers or physicians in general. Can you comment a little bit about clinical trials in China and what's being done to make sure that women are included in these studies? And then also about women in this field, and are there enough women being represented on the research level and in the physician level from women? Because in our hospital, we're by far the minority as women in cardiology.
I may comment on something. So basically, I was thinking that if we want to talk about the composition of whether female doctors or male doctors are more in cardiovascular department, I would say that still male doctors are the predominant groups. But despite of that, there's many organizations in China to try to improve the participation of female physicians, especially in cardiovascular areas. For example, we have our Chinese Society of Cardiology. Under that, there is a special working group, which is a women's health work group under that. So this group is among the 23 special subspecialty groups in this society to try to ensure that female physicians are taking part in the work of the society. As well, they want to emphasize their work on women's health, especially on cardiovascular diseases. Not only this society, there are many others. So especially under there is an organization in China, which is called All China Women's Federation. So this organization is quite large. So they are trying to ensure every organization, those, these societies or college, they want to ensure all of these societies will emphasize on women's health as well. So these are the things I've been thinking about. I don't know whether it is suitable for your answer.
No, that's excellent. And I think we have societies like that too. And what we've found is when Dr. Wan and I were fellows and training together, I think we were there were only 3 of us. I think we made up maybe, what would you say, Elaine, about 10% of the class?
Yeah, right. I mean,
now that's about 50%.
Yeah, every year it got better for me. For the fellowship training, I was 1 out of 5 fellows, so the other 4 were men. And currently I'm the only women electrophysiologist on faculty, and next year we have another one. So definitely things are getting better. I think it's thankful to our institutional policy to try to increase diversity and promote women. I think on a national level, the National Institute of Health also has programs to improve training for underrepresented minorities and women. I think some of I just want to bring it back to the trials that Sonia was talking about is I think it touches on a lot of things what we talked about earlier, is that women may not be amenable to putting themselves first to go into trials that may improve themselves or improve their health, whereas their focus is on their family or their jobs. I'm not sure how you think to change that. I think in the US, we try to do a lot of education and counseling and promotion. I think definitely having principal investigators who are women who can reach out to other women is definitely a starting point. I think that's what Dr. Talani was talking about, having more women cardiovascular researchers and women physicians. Can you talk a little bit about in China, the training program to promote more women? I mean, you talked about the societies. How about in an institutional standpoint in all the academic centers? Do you think there's any movement or promotions of training to women to go up the academic ranks also?
I think we should give this to Professor True, because as the chief physician and the director of your program, I think that women reaching that those higher levels, that's something that we're lagging about in the US. Even though our numbers are increasing, we're not seeing women in leadership in cardiology. So if you could talk about your success and how you managed that.
It is true that we do need to improve the role of the women's in the doctor group. So just to talk about the organization of women's like doctors, I think I want to share that we do have China Medical Women's Association to just like the women doctors to communicate, to share, to enjoy, to do some very joyful things like that. Also, we do have some association in Beijing or in other province. So I think we have more opportunity to improve the women's ability, and I think the change, it will be changed.
Can I make some comment? Sorry.
Yes, please. Yes, please.
Yeah. Sorry for jumping. I just wanted to mention that actually in China, the women's situation is actually not too bad, I should say. Actually, you know that for now, our the chief for the Chinese Society of Cardiology is a female doctor who is Professor Han Yaling. And as well, actually from our hospital, our chief for our department also is the vice president of our hospital is a female EP specialist as well. So I would say that actually not too less. I would say if we want to compare the ratio of male to female physicians in cardiology department, I would say 4 to 6, roughly.
That's great. Have you encountered, like in the US, is there a disparity in the number of women that are included in clinical cardiology trials in China, or do you also find that not to be an issue?
I wouldn't say that we are picking for more male patients or male participants. So we want an equal distribution, of course, from the most of the trials starting point. So for my experience, I had run like for sub-PI, I was sub-PI for 2 clinical trials. One is for a PCSK9 inhibitor trial, which is so this trial for these high risk CVD patients with high cholesterol. So this trial actually involved more women than men participants, because to me, women participants are more active. So they want to, they are thinking about accepting the visits. So they are enjoying the visits and the relationship with us. So they are actually involved more. And there's another trial, which is evaporating, the phase 4 trial for evaporating, the positive trial for the heart failure patients. For this trial, actually more male patients than female patients. But however, so we should say that for heart failure patients, starting from the composition, it is more, you will see more male patients than female patients. That's why we are having less participants, female participants. Yeah.
That's great. And I think those trends are really changing in the US too, as we talk more about the disparities. There's more of an effort to, try to give equal representation, not only in clinical trials, but as I said, as you guys have said, and doing better in your hospitals about equal representation also on faculty and on research teams. The final question I want to give you all a chance to answer, as we've talked about, we've answered some of these questions, but I think to give you just a chance to say a little bit more on this topic is, what are the tools that we use to improve outcomes for women? So, globally, heart disease, we've improved outcomes in a lot of groups of people, and older patients are getting, more medical treatment and more awareness, but in particularly younger women in the United States is the one group where cardiovascular disease rates are increasing. It's thought that this might be due to the obesity epidemic, that it may be related to diabetes, but for whatever reason, we've not done a very good job to reach young women for preventative care. As you said, trying to treat risk factors before disease manifests. We have used in the US, social media and different types of digital tools to try to reach these women. And I don't think we know yet whether we've had success in this group. Do women watch these videos? Do you feel like our issue in the United States is there's just there's so much out there, that there's so many TikTok videos, there's so many social media posts that it's very hard to actually get through to women. Do you find that to be the case, or do you feel like there's an audience for this type of health education?
I just give an example, just like my mother. My mother, she's 68 years old, and every day she will read the social media. She will tell me something about the cooking, the health. So I think it is more popular in China. The social media is a useful tool.
I'm going to let everybody answer, but one more question in this area, and then this is coming from our participants, our listeners, and they ask, and I'll let anybody answer this. What do you think that should be done to reach the women in rural or disadvantaged areas in China? Do you think that they're getting these types of, because you're in, I believe in Beijing, right? So, a different population. Do you think that these public health initiatives are reaching women in other areas? And is the information that they're getting, is it correct and up to date, you think, in other areas? I'll let anybody answer, any of the Chinese panelists.
I would say that if for the rural areas, there's still much to do. If we want to target this group of people, especially young female, this is difficult for now. If you want to emphasize that, let them know that primary prevention for those risk factors for cardiovascular diseases. So this knowledge is, I would say that there's limited access. Even we can provide many knowledge, many patient education in the public platforms, including WeChat, Weibo, and other websites, and the social medias, the TVs as well. I wouldn't say that not all of them, but most of them wouldn't take this knowledge into consideration. So I would say that there's a long way to go still.
And I think we find the same. I'll let Dr. Wong answer on our side. And Dr. Wong, there was another question also that maybe you can incorporate in your thoughts on this. idea is, as someone is asking, you know, do women and men get the same medical care in the United States? And I think you can answer that, and also I think expound on these geographical and socioeconomic differences that we see in access to care and understanding risk factors.
Yeah, well, first I'm going to just say that yes, women and men get the same medical care in the United States. I think some things that are a little bit different is in acceptance of, for example, invasive procedures. I think that's what I find is the most difficult to convince some women to get invasive procedures. Let's say, for example, for atrial fibrillation, ablation, anything that has to do with a needle and them having to stay possibly overnight in the hospital that takes them away from their family. I find that it's difficult for them to get invasive procedures, but overall, the same recommendations for medications, non-invasive or invasive procedures are the same in the United States. As for rural areas, I think that national societies like the American Heart Association and the Heart Rhythm Society, the American College of Cardiology, all of the information is public, right? It's all on their website. So it's put in a very lay language, easy to understand language. So I think there's a lot of promotion of that to have patients understand their problem. But once again, access to this information may be a limiting factor. You know, internet is now widely available. Anyone can, on their phone or on their computer, type in information about that. And sometimes it's too much information and misinformation, misunderstanding of what is actually going on. But I think that information is public. It's just whether or not Disparities is education and getting there to that point and then understanding that, which I think will require more outreach to more rural areas that need people who speak the same language, you know, to understand what it takes for them to understand their issues. There's also a question in the chat about someone experiencing tachycardia. I think this is a great referral for Dr. Chu, who is an electrophysiologist in China, for a patient who has tachycardia. How do they get worked up for that? So tachycardia sounds like it's an arrhythmia problem, but I guess some of their doctors after a Holter said it was normal. Sometimes, you know, a Holter is only 24 hours. Sometimes you might need longer monitoring if you're having the symptoms more than like not every day, but like once a week or something like that. So maybe you need a longer monitoring period to figure out what the arrhythmia might be. And if you're having tachycardia, probably the best is to seek out an electrophysiologist, someone like Dr. Chu, who specializes in heart arrhythmia. Are there any other medical tests? Most commonly is to make sure you don't have thyroid abnormalities. And then there's one last question. Do Columbia scholars collaborate counterparts in China, given limited mobility? And what ways do you think that US scholars or researchers are looking for collaboration? I'm just going to comment this briefly. Yes, definitely. We want to collaborate. And I think that in the day and age of Zoom, which is now acceptable in all sort of meetings or discussions, it makes things much easier. I think sharing of data is a difficult issue that sometimes has to be worked out. US scholars, what ways can we collaborate? Anyway, basic science, clinical research, translational, epidemiology, I think those are all ways to collaborate, but I'm going to open up to my colleagues in China.
Yeah, so I think just in the last few minutes, just like your parting words of wisdom for how do we, you know, how do we change, how do we improve things? How do we, what are the tools? We talked about social media. We've talked about societies promoting, you know, women in the field of cardiology. We've talked about, you know, just access to care issues. And I'm wondering, you know, this is just such a big reach. Are there specific programs, I think, that have been, let me rephrase. We did a program like this in India, and what we found, where we were talking about these same issues. And what ended up happening with COVID was sort of a double-edged sword. because what COVID revealed is a lot of these disparities in care, right? So people in urban areas with access to care were able to get tested and get treated, and in other areas where there wasn't that access, the outcomes were worse. And as a response to that, a sort of more network of primary care of physicians are using non-MDs to have clinics for preventative and primary care in less urban areas. That sort of came up with COVID, and I think provided a sort of a pathway for what could maybe continue on after COVID for preventative care. Have you seen that in China, that this expansion of a network of care that maybe got started because of COVID, but maybe could continue in a different vein to provide preventative care? Professor Chu, I'll let you.
So I do agree with you that we need to use some more net resources to improve the health. I think if we want to improve the women's health, the most important things is let them know their own health problem. So people just care about some items just with a relationship with their own health. So if we have a lot of resources in the network, and they know what they need to care about the problem, maybe that will improve, will get greater improve for their health. So in China, I think we use WeChat a lot. So we also have the official account like microblog like that. So we can let them to we can give them some information according to their own health problem, and maybe it will be better to improve their health education. I think
that's great. So I think we just have a few minutes left here. I want to thank all of you for taking time out of your busy schedules to meet with us. This has been really informative, and I think even though our cultures and maybe very, very different, there's a lot of commonalities that we face as women, and the women that we care for. I think the themes that I heard were that women, not being able to put themselves first, women, of different backgrounds, not getting the correct needed information for understanding that heart disease is a problem, and the risk factors that could be modifiable to improve their health outcomes. But I also heard a lot of wonderful, programs and tools, both in the US and China, to address these. And so as they say, you have to admit that you have a problem before you can fix it. And it sounds like we're on both sides working hard to equalize the care and outcomes for women in cardiovascular disease. And I want to turn it back over to Helena, and I want to thank again the Global Center, Beijing, Columbia University for doing all the heavy lifting, for setting this up, for our wonderful translators. Thank you for volunteering your time to translate this for all of our listeners. And I'll throw it back to you. Thank you so much.
Thank you, Dr. Tanali, for the managing the flow of the conversation so well and facilitating the discussion on such rich subject. I think we have been go through all the important topic that we were originally thinking to discuss with the panelists. Also the comments from Dr. Wen at last about the collaboration between the US and China scholars is quite encouraging. Hopefully that we will be able to facilitate further discussion. I think there are a lot of amazing practice at Tsinghua Changgung Hospital or other Chinese hospital that we can learn from each other. Hopefully we will have follow-up opportunity to to learn more, and also thank you for the generous sharing of your observation and insights from our panelists, and thank you all for attending this webinar. Feel free to reach out to Columbia Global Centers Beijing via email on the event announcement if you are interested to learn more, and we will see you soon. Okay.
Thank you.
Thank you.
Thank you.
You.
Goodbye.
Bye.
Good night.
Good night. Have a good day.
Good morning. Good morning.
Good day.